Okay, am I live? Is this working? Yeah. Yep. So it's okay. So today I'll just be doing general surgery. A few topics I have. I want to finish stomach, spleen, peritoneum, and small intestine, large intestine. Today and tomorrow I will stream for like 12 hours. Just completely I'll be doing this only. But yeah, what do you say? Yeah, let's have some fun. Yeah. I don't really have anything else to do. You know, I'll take some. I'll take break every now and then, maybe 15 minutes in every hour. I don't want to do listening. What is it? I don't want to be like this is this time I have to take a break. This time I don't have to take. Mm. Generally, if I stream for like 45 minutes, I'll take like a 15-minute break. So you can expect that to happen. I need to give my voice a little bit rest also. Speaking for 12 hours straight isn't exactly good for your voice. So last stream we had left off at clinical features of stomach, carcinoma of the stomach. So the patient often will have vague symptoms. So you have early satiety, flatulence, discomfort in the upper abdomen. Early satiety is due to decreased distensibility of the stomach. Anemia is due to you also have anemia due to many factors. So you have SOLID. It is an growth is but manifests as secondaries in the liver ascites, which is nodule, retrovascular deposits, Bummer self, umbilical nodule, system Mary Joseph nodule, and left axillary nodule, iris nodule, and palpable ovarian mass, which is Krugenberg's tumor. So Virchow's nodule is the first nodule which gets affected. Obstruct turn of the pylorus antrum, providing obstruction with VHS or vomiting with or without blood. Visible gastric peristalsis can also be present. Obstruction or cardioesophageal junction produces dysphagia. And you have lump in the abdomen which is hard and irregular clinically. Stomach mass is differentiated from the liver mass by features mentioned below, which is insidious in onset. Anemia will be insidious in onset. Anemia, anoxia, anesthesia of short duration, and dyspepsia. A man of over the age of 40, carcinoma stomach should be ruled out. Early gastric cancer presents as dyspepsia. So yeah, solid. Non-metastatic conditions such as thrombophlebitis, Drosophila, and deep vein thrombosis can occur due to change in thrombotic and hemolytic mechanisms, hemostatic mechanisms. So anemia and carcinoma is one of the most common presentation. Patient gets investigated for anemia by the physician only to detect carcinoma of the stomach, and chloridia results in poor conversion of ferrous to ferric and causes anemia. 15% of the patient also develop hematemesis. Yes, and the ulcerative or proliferant lesions. GI blood loss also account for anemia, and early satiety, loss of appetite, poor intake also contribute to anemia. However, it is a minor rule, and 40% of carcinoma of the stomach patients have anemia. Then, carcinoma of the stomach, large ulcerative lesion with involvement of serosa is shown here. Then, umbilical nodule, popularly called as Sister Mary Joseph's nodule. And then you have carcinoma of the stomach with nodules in the greater omentum. There is nodules in the greater omentum, and this is the meseval lump, large supraclavicular above the clavicle lump. Features of stomach mass. Stomach mass moves with respiration. Upper border of the stomach mass can be made out. Anatomical location of the mass, it is right hypochondrium in a pyloric mass, and epigastrium and left hypochondrium in a mass arising from the body of the stomach. Then near above position, the mass is felt forwards unless it is fixed, and the mass may have intrinsic mobility. of this appetite. You can move with respiration. Upper part can be made out. Anatomic location of the mass is right hypochondrium in a pyloric mass, and epigastrium and left hypochondrium in a mass arising from the body of the stomach. Near position, mass falls forward unless fixed, and the mass may have intrinsic mobility. Then you have Krukenberg tumor, which is spread off, into the Krukenberg. Then you have hard diagrammatic representation of secondaries in carcinoma stomach. So it can be secondaries in the liver, which is nodular liver. You have hard irregular stomach mass. You have omentum deposits. You can see ascites and Krukenberg deposits. Then spread, you have penetration of gastric serosa, the most important prognostic indication. When serosa is not penetrated, 50% survive for 5 years after resection. When serosa is penetration, it becomes 20%. Once serosa is involved, adjacent organs such as liver, pancreas, spleen, omentum, transverse colon gets involved. Lymphatic spread, 420 lymph nodes have been identified. Lymph node involvement proved prognostic indicator. Involvement of 4 or more nodules is less favorable. This is the TNM staging. TX, T0 is no tumor. TXS cannot be ascertained. TIS is carcinoma in situ, intraepithelial tumor without invasion of the lamina propria. T1 is lamina propria is involved, mucosa is or submucosa is involved. T1A is lamina propria, muscularis mucosas, and T2B is invades the submucosa. T1B is invades the submucosa. T2 is invading the muscular propria. Then T3 is subserosal connective tissue without invasion of the visceral peritoneum or adjacent structures. T4 is invades the serosa, visceral peritoneum or adjacent structures. T4A is adjacent serosa, visceral peritoneum, and invades adjacent structure is T4B. Then regional lymph nodes, you have just a second. Regional lymph nodes, you have NX is cannot be assessed. N0 is known lymph node metastasis. N1 is 1 to 2, N2 is 3 to 6, and N3 is 7 or more, and N3A is 7 or to 15 regional lymph nodes, and N3B is 7 to 16 or more. 16 or more is 7. N3B. Distant metastasis, M0 is no distant metastasis, and M1 is distant metastasis is seen. Then histological grading, grade GX is grade cannot be assessed. G1 is well differentiated, G2 is moderately differentiated, and G3 is poorly differentiated, G4 is undifferentiated. So you have lymphatic zones. So lymphatic drainage from the stomach has been classified into 4 zones. So zone 1 is the gastroscolic omentum along the right epiploic vessels, and this drains the pyloric antrum and lower half of the greater curvature. Zone 2 lies in the gastrocolic omentum and gastrosplenic ligament along the left epiploic vessels. This drains the upper half of the greater curvature. Zone 3 is in the lesser omentum, draining proximal 2/3 of the stomach. From here, the lymph node drains into periesophageal lymph nodes. Zone 4 is the distal portion of the lesser curve and pylorus along the hepatic artery and right gastric artery into the para-aortic artery nodules. So again, zone 1, zone 2, zone 3, zone 4, bottom right, upright, but upright, but up left, but this thing, okay. So greater curvature, pyloric and body, greater curvature, near the antrum, upper half of the greater curvature, upper half of the lesser curvature, lower half of the lesser curvature. Like that it will go and it will spread to the lymph nodes. You can remember. Then blood spread. Most common sites are lungs and liver. It produces selective secondaries. These are signs of inoperability. Transgenomic spread results in ascites, Krukenberg tumor, bilateral bulky ovarian deposits, and retrovesicular tumor. Bloomer's shelf. Then investigations. You can do CBC 20%. Okay, wait 1 second. I haven't been marking anything right here. Not penetrated. Serosa is penetrated. So lymphatic spread, yeah, go for 20. Zone 1 is again in gas recommended great patients. Yesterday, on the greater curvature. Approximately two-thirds. Distribution of lesser curvature paraortic lymph nodes. So just look at the time. So investigations you can do CBC, which is 20% of early gastric cancer patient have iron deficiency. Microcytic hemochromic anemia, preoperative blood transfusion may be necessary. Routine examination, fasting, postprandial seizures, ECG, renal functions for fitness before surgery, flexible esophagoscopy. Flexible esophagoscopy to know the extent of lesion, confirm diagnosis, take multiple biopsies, 6 pieces, and also to aid brush cytology. So this is endoscope showing superficial ulceration, endoscope showing ulceroproliferative growth, and here there is a friable granular tissue and antral carcinoma. Fundal carcinoma detected by J maneuver in the endoscope. So ultrasound and CT you can do. Rule out secondaries in the liver, look for elastic nodes, detect ascites, Krukenberg tumor, metastatic. Endoscopic ultrasonography can differentiate early gastric cancer from advanced tumor in 80% of the patient. Overall accuracy is of the staging is 75%. Laparoscopy is CT cannot detect liver or peritoneal metastasis less than 5 mm and small lymph nodes. So laparoscopy is an ideal investigation. Almost 20 to 30% of operative cases become inoperable. Laparoscopic peritoneal lavage for cytology is the best test. Barium meal may show intestine persistent irregular filling effect. Double contrast air barium study is used for detecting early cases in Japan. It is also used in case of linitis spastica. Today we use barium, and the use of barium has become almost nil with the availability of endoscopy. Then you have CEA, carcinoembryonic antigen, is elevated in 60 to 70% of patients, indicates extensive spread of disease. Histopathology, adenocarcinoma of the stomach. There is basically two types of gastric carcinoma as per Lawrence classification. Diffuse is more common in young female and carries poor prognosis. Leather boiled stomach or lentes plantica is poorly differentiated with anaplastic cells. Intestinal is more common in elderly males. It shows area of intestinal metaplasia and it has better prognosis. Entire thing is important. Adenocarcinoma. You have diffuse and you have proliferative in the intestine. Carcinoma of the stomach, barium meal showing a large irregular filling effect along the greater curvature. Hourglass contracture in the stomach caused by carcinoma is also here. Treatment of carcinoma, surgery is the main modality of treatment. Adjacent chemotherapy has been found to be beneficial in a few patients only. Resectable means the growth can be removed. Inoperable means there is no chance of cure, but growth may be resectable. Operable means cure is possible. Signs of inoperability you have growth fixed to pancreas or posterior abdominal wall, secondaries in the liver, hard nodular liver, retrovesicular deposits due to peritoneal seedings which failed during parietal examination, enlarged fixed celiac nodules, para-aortic nodules, and left supraclavicular nodules. We have Krukenberg tumor and malignant ascites. Sister Mary Joseph nodule also will be seen. Fixed celiac nodule is a case of abnormality retroscleral. Fixed growth, secondaries in the liver, retrovascular deposits. Krishna Mary Joseph was head nurse to William Mayo. He was the first to notice that a nodule in umbilicus was often associated with advanced malignancy, present as a firm red non-tender nodule. This was from spread of tumor within the falciform ligament. 90% are adenocarcinomas. Commonest primaries are stomach and ovary. Primary tumor is almost always invariably inoperable. So aims of surgery is curative resection should be done whenever possible and bypass procedure. Gastrojejunostomy to relieve vomiting in advanced cases of pyloric obstruction. Palliative gastrotomy can be done to remove a fungating ulcerative bleeding mass. It is giving better palliation. Aims is never you have to learn. So curative resection, if it should be considered if no evidence of microscopic gross residual tumor, serous is not involved. Thus means curative resection is not possible for T3 and T4 tumors. There is no evidence of metastatic disease. So Japanese research study indicates resection including lymphadenectomy. So it's given interval, but however, the rest of the cancer research group were not able to produce the same result as the Japanese. D1 means removal of primary group of lymph nodes such as nodes along the lesser curvature and nodes along the greater curvature and juxtapyloric nodes. D2 refers to the removal of lymph nodes such as left gastric, common hepatic, splenic, retropancreatic. These becomes curative resection when lymph nodes are clinically enlarged. N1. Okay, so removal of lymph nodes. So the greater and lesser curvature and juxtapolar nodes, and this one point is really not important. I don't understand why it is you mentioned here. Okay, D2 refers to removal of lymph nodes such as left gastric, common hepatic, splenic, retropancreatic nodules, etc. This become curative resection when N0 you have to do this, N1 you have to do this. Like that's the only thing I can think of. D2 is left gastric, common hepatic. Splenic, retrosplenic, etc. D3 is removed lymph nodes such as para-aortic, para-hepatic nodules behind the head of the pancreas, etc. It is never done. So N0 is D1, N1 is D2. You have to do. That's the only thing which this one point, if you remember, it's enough. D3 is never done. Extent of gastric resection. So gastrectomy is site dependent and focuses on the complete removal of gastric carcinoma with preferably 6 cm margin from the gross edge of the tumor. Then you have perigastric nodules, right pericardial, left pericardial, lesser curvature, greater curvature, and suprapyloric, infrapyloric. This entire table is number, station, description. I mean, it's okay. You don't need to learn anything. Players who extend audio dissection in tumor in distal one third of stomach due to dissection of tumors in the proximal third of stomach. Clearly, anatomical limitation influences the margin because in antral lesion close to or involving the pelvis, only a limited portion of the duodenum can be removed. In a patient with distal lesion, essentially a distal subtotal gastrectomy is performed regardless of the T stage. Therefore, for proximal funded total gastrectomy, for mid-body or more extensive lesion, total gastrectomy. Distal lesion, subtotal gastrectomy is performed. And we have operative photographs of carcinoma of the stomach, carcinoma of the stomach with involvement of serosa. Echo sonogram can detect this. Total gastrectomy, diffuse carcinoma of the stomach, known for transmural spread. Open stomachs, loss of rugae, nodal cancers, tumors. Subgastrectomy for antral carcinoma, they present with gastric outlet obstruction. Peritoneal metastasis from carcinoma of the stomach, laparoscopy is the most ideal investigation to detect peritoneal metastasis. Intestinal type gland formation is present similar to adenocarcinoma of stomach, good prognosis. Let's move on. So, pathological basis for T2 dissection. Gastric cancer has great propensity to spread through the rich plexus of lymphatics of the stomach to local or regional lymph nodes. Hence, the need to remove stomach and lymph nodes. Gastric cancer, unlike breast cancer, remains for a long time as a loco-regional disease. It is striking too when gastric cancer recurs. It often does so loco-regionally rather than more widespread dissemination. It is very rare for gastric cancer to recur 5 years after surgery. Whereas for breast cancer, disseminated micrometastases continue and can take their toll in 10 to 20 years after surgery. It's rare to recur 5 years after surgery. Has a great propensity to spread through the rich plexus of lymphatics of the stomach to the lymph nodes. For more distal lesions, a subtotal gastrectomy is the preferred approach. Extended organ dissection is reserved for patients with apparently node-negative T4 lesions, in which complete resection requires resection of invaded portions of the diaphragm, pancreas, spleen, and adrenal gland or colon. Patients are usually treated with chemotherapy. To extent of lymphadenectomy, you have typically grouped into N1 stations 3 to 6, N2 1 to 7, 8, and 11, and N3 9, 10, 12. session. Basically, yeah, this thing. You don't have to remember this, but yeah. Roller session, if you vary depending on the level of tumor. In general, into this one thing is, if you remember, it's enough. N1 nodules are within 3 cm of the tumor, N2 nodules are along the hepatic and splenic arteries, and N3 are the most distant. Extent of gastric and lymph node resection, upper 1/3 of the lesion. Tumor is considered resectable if confined to stomach or N1 and N2 lymph nodes are involved. Nodes less than 3 cm from tumor, N1 nodule. Nodes greater than 3 cm from tumor, N2 nodules. If tumor and N1 nodes are resected, D1, D2. D3 dissection is a D2 resection plus removal of para-aortic lymph nodes. Standard D2 involves removing a part of stomach, N1 group, N2 group. Then spleen and tail of pancreas. D2 recession mental bursa. Apododuodenal nodes in heterodynes and splenic artery nodes. R resection is described by Hermack, used to describe the tumor status after resection. So R0 describes a microscopically margin negative resection in which there is no gross or microscopic tumor. It remains in the tumor bed. R1 indicates removal of all microscopic diseases but indicates that microscopic margins are positive for tumor. R2 indicates gross residual disease. Since the extent of resection can influence the survival, some authors include designed to complement the TNM system. Long-term surveillance can be expected only after the R0 resection. Therefore, significant effort should be made to avoid R1 or R2 resections. If no disease is identified in the lymph nodes, not nomenclature is used. Microscopically margin negative resection is gross microscopic tumor remains in the environment. So is it one test not there? Distension, acute dilation of stomach not there. SRS you have to do, IHPS. Obesity, I don't think it's there, but you can do it. So, key points and special notes to the students. Endoscopy has revolutionized the diagnosis of carcinoma of stomach. Of course, it has. Early diagnosis should be the aim since only early carcinoma of the stomach is curable. Sonography, CT scan are the investigations to detect intra-abdominal metastasis. Endosonogram detects various levels of the stomach which are ignored by the tumors. Diagnostic laparotomy detects the peritoneal metastasis and has no role for radical surgery. Resection is the best line of treatment which can be curative in a few patients. Any radical surgery will involve a wide excision of the tumor with lymph nodes and momentum. Because of added morbidity of a very small survival advantage of D2 resection of D1, many still consider D1 resection as adequate. As far as concerned, understanding these various terminologies will enable you to score better in theory papers. A simple summary of surgical procedure has been given here. Endoscopy has revolutionized. So that's all. So proximal gastric you can see left cardiac, right cardiac, lesser curvature you can remove in R1, in R2 you can also have greater curvature and consolidation. In optional, you have suprapulmonary, left gastric, hepatic, celiac, splenic hilar and splenic. In additional cancer, you have this. And in mid-body cancer, you have these. Summary of treatment: you have carcinoma of the pyloric antrum and distal part of the stomach. Radical septal gastrectomy, which includes removal of 60 to 70% of stomach. Greater momentum along with enlarged. Then carcinoma of the proximal stomach and diffuse carcinoma, you have esophageal carcinoma. Followed by esophageal stomach. Palliative surgery is done to relieve vomiting by anastomosing jejunal loop to stomach in the peripheral region. If posterior GJ is done, the growth may involve the GJ stoma early, resulting in stromal obstruction. With anterior GJ, enterostomy can be added to prevent bilious vomiting, and palliative gastrectomy to get rid of ulcerative, necrotic, or bleeding lesions. Endoscopic mucosa resection is indicated in early gastric cancer confined to mucosa and cancer stabilizing to centimeter, and there should be no node enlargement. So, how much long? 10 more minutes. Let's do. Yeah. Endoscopic mucosal resection indicated in early gastric cancer confined to mucosa. Cancer should be less than 2 cm and there should be no node involvement. Ideally, cancer should be elevated variety as well as differentiated. Normal serum is injected into some mucosal plane and lesion gets elevated. It is excised with 1 cm margin along with 2 muscularis paparia to at a devo plane. Endoluminal gastric surgery has small high patients already arthroscopic instrumentation and endoscopic guidance. Key points on surgery for carcinoma of the stomach. Carcinoma antral body is radical subtotal gastrectomy. Proximal stomach is radical total gastrectomy. Inoperable is palliative anterior GG. Radical is removal of lymph nodes, fat aggregation in one are removed with stomach. It is a T1 gastrectomy in level 7 to 1 into with 1 to 6 node and stomach. Is called due to early gastric cancer without lymph nodes can be treated with endoscopic mucosal resection or gastric resection. Palliative gastrectomy subtotal is worth considering inoperability. This is obstruction of breathing. Paraneoplastic syndromes associated with cancer stomach. You have Trousseau syndrome, which is thrombophlebitis. Acanthosis nigricans, which is hyperpigmented. Of axilla and groin and peripheral neuropathy. The adjuvant treatment is understood that gastric cancer partially responds to chemotherapy. 30% given at advanced stages as inverted cancer. Fluorouracil daily for 5 days. Every 28 days can be an infusion available for 15 minutes. Anti-metabolic has side effects, DNA synthesis side effects are myelosuppression, mucositis, excessive lactation, nausea, vomiting, etc. 5-fluorouracil, mitomycin, and cisplatin has been tried. However, toxicity is small. FM, 5-fluorouracil, adrenomycin, and mitomycin C, and ECM, epirubicin, cisplatin, and 5-fluorouracil have popular agents. Post-operative chemotherapy, you have a few things. Post-operative chemotherapy depends on the type of resection done. R0 is free margins. Any tumor other than T2, including selected T2 cells, should be considered for chemotherapy or includes one cycle of fluorouracil with or without glycogen and capacitive chemotherapy. 5-fluorouracil with or without chemotherapy, chemoradiation. R1 and R2, regardless of the name, should start as a chemoradiation followed by further cycles of adjuvant chemotherapy. I will just say one cycle of 5-fluorouracil required. These names are important, I think that's it. Yeah, knowing that, if patient has received pre-operative chemotherapy or chemotherapy patient, then adjuvant therapy is usually recommended beyond T2 and 0, which is 5-fluorouracil with glycogen or capecitabine based. Patient has only pre-operative chemotherapy with resection of 1 or 2, then post-operative chemo radiation is advised. Neoadjuvant chemoradiation, it is advised in medically fit unresectable locally advanced disease with generally involves concurrent 5-fluorouracil and capecitabine based chemotherapy. Chemotherapy alone may be used as a neoadjuvant modality. Recommended radiation dose is 45 to 504 mg. Metastatic gastric cancer, you have trastuzumab, which can be used as a metastatic or locally advanced gastric adenocarcinoma which are accessing HTR2 new receptors. External beam therapy can also be used in metastatic cases. 50, 30 introduction of topics. Leomyoma is a common and it is called restricted Stomach is the most common site of this. Bleeding is common presentation. Appearance of cervix. GIT gene amplification. CT scan. Bleeding inside of the stomach. Adenomas. A large GST arising from the fundus of the stomach, presenting as a nodular mass in the left hypochondrial dissected successfully along with the spleen. CT-GST fundus. CT-GST differential cut. GST surgery. GST specimen diffusion from the stomach open to show fleshiness. The base imatinib. 4 caps out of 4 enzymes and little toxicity appears or metastasis or residual tumor remission. Carcinoma in situ, like that also is there. So it's like GIST carcinoma cervix. Sorry about that. Spleen, mucosal ulceration, nodular mass. Large yeast arising from the fundus of the stomach, presenting as a nodular mass in the left hypochondrial dissection successfully along its spleen. Yeast fundus, I think this one. Fleshy mass is here. GST can do chemotherapy. Imatinib. Okay, I'll take like a 15 minutes break. Be right back. We can finish in an hour. Whatever it is. Okay. ಏನೋ ಮಾಡಿದ್ರಾ? I mean, yeah, I'm here, but just a minute. I had to do something. Okay, so let's move on. Gastric lymphoma. Incidence of primary gastric lymphoma is increasing. They are B cell derived from mucosal associated lymphoid tissue, MALT, which is also called maltoma. Weight, pain, weight loss, and bleeding account presentations. 6 decade is the common age group, and endoscopic features are not specific but diffuse thickening with or without ulceration can be seen, and rule out is by CT, ultrasound, bone marrow aspiration. Gastrectomy is the best treatment. Chemotherapy for systemic disease. Low-grade lymphoma associated with H. can regress and totally disappear after eradication. Treatment for H. pylori can be classified as novocultumy, complication of GI, or complication of gastrectomy. My voice is actually paining a lot. Complications of vagotomy have stresses of food in the stomach resulting in nausea, loss of appetite, distension of upper abdomen, bowel irritation, etc. Denervation of gallbladder can cause gallstones. Post-vagotomy diarrhea can be troublesome at times. Vagotomy produces hypoacidity which allows bacterial proliferation. Nitrates are reduced to nitrates which are carcinogenic. Such a malignancy develops when at GJ site it is called stomach carcinoma. Post-vagotomy diarrhea can be very troublesome. Denervation of gallbladder leading to gallstones. Stasis of food in stomach resulting to nausea, loss of appetite, distension of upper abdomen, foul evacuation. So causes of diarrhea. Vagotomy results in removal of parasympathetic influence of foregut and midgut. Then you have fast gastric emptying occurring due to gastroduodenostomy or gastrectomy. Hypoacidity resulting in bacterial proliferation causing enteritis, and bile salts also play a role. Complications of the stromal obstruction. It is due to edema in gastroduodenal anastomosis of independent drainage device in gastroduodenostomy. Fat in transverse mesocolon undergoes necrosis resulting in obstruction to the lungs. Stromal obstruction in case of narrowing of lumen. Conservative treatment, surgery may require later. Gastrographin studies. Retrograde gastric intersusception. It has a afferent of lips and all. Such a properly it can occur at any time after surgery. History of abdominal surgery, period of pain, omitting something blood smell, performance and that initiation within excision. There is no gastric intersusception. In gastric intersusception, treatment is reduction of intersusception, rupturing of the intestinal lobe. Gangrene of the intestine. Gastroduodenal chronic complication of GI don't have particles, especially vagotomy is not an inhalation complete. After a few years of GJ, recurrent ulcer develops a GJ site. Recurrent ulcer slowly inertia adjacent structures such as transiscan resulting in gastrognostic fistula. Clinical features have cases to hygrotomy and GJ. Whole evacuation and false sounding normal due to colonic contents entering the stomach, which is loaded with fecal matter and fecal contents. Intense diarrhea, metasevioritis, water by the colonic bacteria entering the jejunum. Rapid deterioration in inflammatory mass, loss of appetite. This one double reception, Dysnomaconic fistula is fecal matter in the stomach coming from colon. See the triangular folds of the colon. Triple dissection. Gastrectomy for stomach cancer is carcinoma stomach apparently when apparently endoscopy showing stomach carcinoma. This was in the patient with kidney with stomach carcinoma, which was in gastroileostomy is the highest spindle in surgery can do. Available complication. Instead of short loop of this is alien there will be severe uncontrolled area and loss of weight emancipation within a short period of time. Mirrored meal fluoroscopy should be done with orbital ovarian meal from the stomach into the ileum. Nephrotomy and undoing of the gastroileostomy and fresh gastroileostomy should be done. Gastroileostomy, the biggest spindle, it can be avoided by identifying the duodenal fixture. Post-cerebral syndromes efforts results into rapid emptying of stomach contents inside the distal intestine, resulting in various physiological changes such as vasomotor symptoms, hypoglycemia, etc. The post-cerebral syndrome. Appreciation, gastrectomy, nutritional disturbances, intermediate patient deficiency, megalovastic anemia due to atrophy and iron deficiency anemia. During his bypass, because of deficit, iron absorption. And pulmonary tuberculosis. Susceptibility. Dumping syndrome is post-cycle symptoms. Early and late. Early is due to increase in taking immediately after meals, and late is 2 to 1 to 2 hours after the meal. Post-cycle syndromes. It is caused by rapid passage of food of high osmolality from the stomach to the small intestine, causing hypovolemia. Late is due to late initial hypoglycemia and causes increased release of insulin, which is followed by hypoglycemia. Relief in early is by lying down, and late is by glucose. Aggravating factors is more food, glucose, and fullness. And late cases, aggravating factors are exercise. Symptoms: you have epigastric distension, setting, diarrhea. In late cases, you have tremors, fainting, attacks, release of adrenaline. Treatment is by small quantity dry food over a period of time. Symptoms settle down, less sugar content. And you have to do in late. Cycle late is fast. Symptoms. Comparison of chronic half-intelligent syndrome and gastric. MBBS. Chronic duodenal illness. Okay, dumping syndrome is there. Let's do dumping syndrome. Comparison of this entire thing was important. Chronic afferent limb syndrome and alkaline reflux gastritis. Pain is after the meals in chronic afferent limb. And alkaline reflux gastritis. It is unrelated to meals. Vomitus is bile, relieves pain and reflected in chronic afferent limb. In alkaline reflux gastritis, there is no change in pain. Non-projectile and alcohol bleeding is rare in chronic. It is common in alkaline. Cause is limb obstruction, long loop, and here the cause is enterogastric reflux, no obstruction. Treatment: you have to avoid long loop at surgery, convert Bildot 2 to Bildot 1, ROX, NY, jejunostomy. Then you can do high fat amino acid regimen and proton pump inhibitor. They ursodeoxycholic acid and jejunostomy, converting Bildot 2 to Bildot 1 can be done. Then duodenal fistula, you have duodenal blowout. It is a leakage of renal contents into the exterior. It commonly occurs after surgery. It is caused after partial gastrectomy or total gastrectomy, where the closure of duodenum was difficult. After the closure of perforated duodenal ulcer, which gives way once again. injuries to the duodenum during right hemicolectomy, right nephrectomy, etc. So precipitating factors: faulty technique of closure of duodenal stump, severely inflamed duodenum, or due to an active inflammation ulcer. If there is distal obstruction, it increases tension in this duodenal loop and may result in fistula. Ischemia of duodenal stump. Polytechnic severely inflamed duodenum due to an active ulcer, duodenal obstruction. Ischemia of the duodenal stump. Clinical features: signs and symptoms develop usually after 4 to 5 days, and all fluids are commenced. They stimulate outflow of biliary and pancreatic juice. Severe abdominal pain, guarding disability, hypertension, sharp seizures of biliary peritonitis develop if there is no denture. If time is kept in for surgery, bile flows to the external. In such a case, there is signs of peritonitis and usually not present. However, severe electrolyte imbalance can occur. Conservative treatment: it heals in a few days provided there is no distal obstruction. Hydration and electrolyte care is appropriate in diabetic. Surgically, fistula persist. Operotomy inclusion of the fistula can be done by repairing with non-observable sutures. Complication: biliary peritonitis, septicemia, bile is not drained outside. Excoriation of abdominal skin. Fluid electrolyte imbalance. There can also be recurrent ulcer. Okay, recurrent ulcer can be there. It can be true anastomotic ulcer, gastroduodenal and duodenal. So there can be a lot of different things. Like, okay, this is a way better thing now. It doesn't really hang on my computer. It doesn't put any pressure on it. Not that you put a lot of pressure, but I think this is fine. So recurrent ulcers can be there. It can be two anastomotic ulcer, gastroduodenal, or adrenal ulcer, or gastric ulcer in remnant or recurrent ulcers following highly selective vagotomy. Okay, incidence is 3% after Villa to 40% after gastrostomy. Highly selective vagotomy. Causes of recurrent ulcer: having complete vagotomy, GI alone, inadequate gastrectomy, narrow stroma, Solinger Renaissance syndrome, and hyperpopulation. appear within 1 to 2 years of depression, persistent pain, boring type. Monitored by interested American narcotic acid may manifest as hematopoiesis, brain or anemia, perforation characteristic, peritonitis. Gastroscopy, hypocalcemia, and hypogastria. Consider treatment with stomach receptor. Before surgery in cold cases. Okay, and acid function test, nothing. Acute irritation of stomach. Acute irritation, nothing is given. All lines of the stomach we have it is a rare condition in which stomach rotates in the horizontal, axial and vertical mesenteric coaxial direction, resulting in acute actually is more common. Common moves upward and later carried curvature of the stomach. Associated eventuation of the diaphragm which also precipitates the condition. All the studies on the paralysis of hernias and clinical features include epigastric pain, fullness and tenderness. Onset is sudden, constant, severe abdomen pain, recurrent wrenching with production of little vomiters and inability to pass any sagacity. Diagnosis: pain, X-ray, abdomen, chest, gas, and discuss. Bearing meal, can subtestosterone, can repel GS. Treatment is by reducing the bowel gas, loading gastric abdomen, fixing the gastric convention to the duodenal infection, perform GI treatment, repair of aortic lesion, and fixing by duodenal camels. Yeah. Okay, I'll finish it off within a few minutes. Actually, this thing it's kind of done. So yeah, tribenzar is a collection of non-digestible material, usually vegetable oil, phytobenzer, and Trichovenza, common concentration of hair found in elongated women who often deny eating their own trichophagy. Trichovezar. Trichovezars are commonly found in patients who have no stomach and difficulty emptying, and diabetes with autonomic neuropathy. Patients are also at risk. Early sedentary weight loss, nausea, vomiting, glucose control, absorption with the patient gets over horses, last mass for background clinical examination. Variant examination of endoscopy. Papain, enzymatic therapy to an atom dissolution of benzoate. So, EMT, adult meat tenderizer. Synonymous with some success, aggressive or tube dose or endoscopic fragmentation. Failure will necessitate surgical removal. Okay, so entire stomach has been done. I don't think anything else is important they can ask. Double contrast study, maybe. I'll see. I'll have to check somewhere else. I don't think it's there in this book. So I'll be taking a break for some time and I'll catch you guys in a minute. So, yeah. हाँ. Thinking game about fire type. हाँ. ಚೆನ್ನಾಗಿದೆ ಅಮ್ಮ ನೀನು ಬೇಡ. ಇಲ್ಲ.
jump scare me now, Lloyd. Why? What was that for? What did I miss? You fucking idiot. Oh, what a dumbass. Come on, try to scare me. Oh, I'm a fucking prideful like dumbass. Fucking fell on your ass, didn't you? Lloyd. That was so easy. That was free. That could have been his prime, though. What happened to him? What did Rambley do? Rambley, the rogue AI? Can he just jump over? No, he's a dumbass. He got his ass beat, and now because he's a lion, and they travel in prides, now his pride's been damaged, so let's get the fuck out of there. Oh, it just doesn't make sense. Ooh, there's the key. Come meet Finley at the Oceanic Odyssey. I can see what he means. That is terrifying for a kid. See this massive sea monster? Can I just break the game? The fuck? Do I have to avoid him? Lloyd, it's not cool anymore. It's actually kind of fucked up. Lloyd, it'll be good. You're not gonna bite me, are you? Lloyd. You're being awful quiet for an 8-foot-tall lion. Don't like it, don't like it, don't like it, don't like it, don't like it. Okay, I'm fucking out of here. Bye-bye. Bye-bye. Later, Lloyd. Ah! Okay. He didn't attack me. Whoa, hey! Jesus, I shouldn't have fucking said anything. What is that? Big bird? Oh, God! I shouldn't have fucking said anything. What is that? Big bird? Oh, God! I don't like it here anymore. This place sucks. I'm not saying anything. I just want to get to Jetstream Junction, and I want to get the fuck out of here. This would be your moment to leave forever. You got attacked by something, your wrist made a noise. Okay. Ooh. Why did I hear a high-pitched beep? I think it was the wrist thing went off and saved me. Ramby's watching my back, or my front. I don't like that the birds wander around somewhere, though. Alright, we're just gonna get Jetstream Junction. Oh, should we fucking drink so much bird up that we shit ourselves? Bird up, Kohler, soda, Dr. Muncher, water and diet water. Oh, that's funny. Okay, we got it. Ramblers, I got it. We're good now. I'm about to die. actually, no, it's building your own barbecue, bacon, burger. Indigo special loaded hot dog. Not enough? Get it Rambley style. I don't want to get anything Rambley style. I don't even want to think about anything being Rambley style. I don't even like the words Rambley style coming out of my mouth, let alone going into them. At least if I close the shit up here. Come on, I came up here all Rambley style. What the hell is the point? I mean, the plane looks cool. Sure, why not? But collectively? I'm sorry, you wanted your burger with barbecue? And that was also a bacon? What the Sigma? Ugh. It makes me uncomfortable. Footsteps. It's the fact that collectible, yes, yes. Oh yeah, look at cutie. Hello. What did I get? Oh, I'm gonna have to go back to the fucking Rambley information kiosk and find out all about that. It's gonna be sick. Priscilla the poodle? Oh. This is horrible. No. It's like Rosie crashed into the light again. Don't worry though, Mr. Hal Rambley has the repairman on speed dial.
We're sorry. The number you have dialed has been disconnected or is no longer in service.
Makes sense.
Please check the number and dial again.
Rambley, I hate to say it, but a second Molly has hit the park. Rambley style. Whole place getting fucking mad Rambley. Molly's letting me in. This is fucking my up. Is this a short person accessible? Can't reach that height. Woohoo! Talk about a color overload. Wait. Okay, I'm assuming I have to find these within the place. Now this is what I call Rambley style. Wow. I sure did get rambled on. Go in. Whee! Okay, how do I solve this? I don't see any indications for anything. Did I miss anything up here? Oh, how do I get up there? Me want uppies. I don't get it. I mean, there's like a pink purple star. Does that mean you're a star? Oh. Okay, got it. Figured it out. I broke everything. Oh, everything's gone all Rambley. What the fuck? space. I thought I was going away from you. It fucking stopped. We're fine. We're fine. I'm just tripping balls. Okay, orange circle. Whee! Crunch. Any more? Oh, this is the start. Wait, let me put in orange circle first, because I'll forget. Or yellow, whatever. Okay. Nailed it. I guess you could have just done this one until you got the star and it would have opened anyway. Okay, Big Bird. Red star. Ooh. Huh? Huh? Okay. You just fucking die if you go into the balls, I guess. You just black out and wake up. Red star, red star, red star. Okay. You guys are here to help me, so you're gonna remember red star if I forget. Green triangle. Red star, green triangle. We got it. Cool. Lock it into your brains, okay? Red star, green triangle. Fucking locked in, connected, Ramley style, baby. Woo! Woo! I don't think that one worked. Blue star, blue star, green triangle. Red star, blue star, green triangle. Red star, blue star, green triangle. That works. Is that all of them? Oh, crunch. I'm gonna fucking slide in on a real way. Red star. Green triangle. Blue star. Woohoo! Molly's landing pad is open. Time to fly into the heavens and break my neck. That's fun. I like that. Some of these games, like Poppy Playtime's gotten... Sorry to keep comparing the two, but Poppy Playtime's gotten way too fucking complex with some of its puzzles. It's like, that's not why I'm playing the games. I'm not there for that. I just want fun, straightforward gameplay. And a couple of scares. Oh, down I go! What did I do? Christ. Ooh, hi! 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 What do you want? I don't have any seed! The fuck? That dude caught up to me fucking randomly split! Damn! What? Molly can repeat words that she's heard. Don't be fooled. Press E to respawn. I gotta kill my fucking Molly ringworm. God damn it. That was intense. Okay, did this do anything? Oh, it opened those doors. Okay. Dude, you gotta be fucking quick. Whee! Oh god. Oh god! Oh fuck! Molly! You can't come from one side and then suddenly you're in front of me! That's Poppy Playtime's bullshit! You can't be pulling that shit, okay? You're better than that! Fucking Molly. God damn it. Hate Molly. Molly sucks. This is why I keep calling you Molly McCock and Balls. Yep, yep, yep. It's like I'm running away from Dog Day all over again. Molly, no! That's me. Rambley's Wrangler. Here to save the day. Alright, Rambley, what are you? Oh, fucking overnight watch? What in the iris is this? Hell yeah. At least I don't have to worry about the fucking bird following me anymore. They fucking day. Hell yeah, that was awesome. As soon as the door wasn't opening, I was like, is the door gonna close on them? And then it was so much worse than I thought it was gonna be. Oh, collectible trash bag? Fuck yeah! That's Terry Trash! This is where he, no, this is where he came down. Ooh, information kiosk. I got a new thing. Poodle plush. It's a weird poodle plush. It doesn't seem to be an Indigo product. Sure does character I've seen, or you've seen in the park. Maybe a child left it behind?
Hey, buddy, did you pick that up at the lost and found? Or was it in the trash? Not surprised to guess that our park would dispose of non-indigo trash plate. I suppose they make playtime special for a child with poor taste, though.
Okay, weird. Weird. Are we in Pirate Cove? Oceanic Odyssey. Ah, right.
Wow, you made the Oceanic Odyssey. Wow, you're doing a great job, Rookie Wrangler.
Thanks. He's so supportive. What a guy. I think Rambley's the best thing that's ever happened to me.
You'll find out cookery and porpoises, pickles, and perches as far as the eye can see. Please don't tap the glass. Really clever.
If that other thing was full of blood and is alive, then that thing is massive.
Hey, buddy, you okay?
No.
You look kind of tired. Do you need a moment? Don't worry, it's fine. I don't blame you for taking a
Are we
rest
done?
and all that. I could go for a nice, relaxing defragmentation myself. But before you settle down, you up for a little survey to help us improve the park? Thanks for visiting Indigo Park. Hope all your dreams came true. If you've got some time and you're up for a lark, stick around for the Rambley review. I'm here to offer my best to each valuable guest I assist. And lots of happy feedback ensures I get to exist. Were you satisfied with the rides? Yes or no? Were you satisfied with your guide? Sure hope so. Do you plan to go back? Will I see you?
Ini tuh kan? Mana?
very special to us. But with the scale of this game, we're going to need some help. If you enjoyed your experience with Chapter 1,